Gel minder is an SS box. Gel means the G for GLP-1 receptor drugs minder. You can use the two important drugs like the liraglutide or maybe the empagliflozin. The main differentiating points here, the diabetic is the significant acidosis should be there, and the criteria that we know about from the lectures with the simple strategy for the diagnosis, the hyperglycemic hypoglycemic state. So definitely the diagnosis type 2 diabetes. Type 2 inhibitors equal to post-MI, having the history of the MI and having the slight blood pressure, and the most important talk, yes my dear, plus obesity. Hello my dear doctor. Let's discuss a very good question discussions on endocrinology my dear. So welcome to endocrine, some important question discussions my dear that are very important for your exams my dear. So let me start by starting the first questions from the endocrine. So let me start from the question number 1. If you say that according to the question approach, we always start the question reading from the main questions. So yes my dear, the main questions, if I go through here, which of the following is the most appropriate interventions for the blood sugar control? Yes my dear, it will induce you actually what will be the best answer. So here is the options. The second is the first step. As I say, the first step, you should read the main questions rather than reading the full scenario first, then going to the answer options like add metformin, add empagliflozin, and add glycoside, and also the switch to the biduren and switch to liraglutide. So these are the options. So immediately after the reading all the options that you need to think about, yes, the different SS boxes and the important knowledge that you have, my dear. So what the knowledge that you had, this is important. Switch to liraglutide is nothing but the gel, my dear, is an SS box. Gel means the G for GLP-1 receptor drugs minder, the GLP-1. Yes. So GLP-1 drugs are nothing but E for, yes, the exenatide. Yes, my dear, the exenatide. And also the L for liraglutide. What I said, the liraglutide, my dear. So this is all over the gel. So GEL, yes, my dear. You can take another color so that you can, this is not the GEL, so this is the gel. So this knowledge that you already know, right? So yes, my dear. So this is gel. So gel, the exenatide and liraglutide at the end of the box, the exenatide is nothing but the box is the indications for the excess BMI, and E for excess insulin. So the indications of exenatide when the excess BMI is more than 35 and when there is a need of excess insulin. So this is a very good drug, the exenatide or liraglutide, and sometimes the new drugs are semaglutide. So these are the glutide group of drugs so that you can remember for the excess BMI and also excess insulin. And another thing, Maya, if you go back to the empagliflozin, the drug, this is a drug, yes, Maya, the empagliflozin is nothing but the SGLT type 2 inhibitors. So you'll have a very good lectures on that, the SGLT type 2 inhibitors, but you must know these drugs also can be used with the obese. Yes. But one of the differentiating points in between these two, these drugs can be used in CKD, means the renal impairment. Yes. In contrast, these drugs can be used, but these also limited if there is an EGFR is less than 35, sometimes saying something less than 45. So it's not used EGFR less than 45. So yes. So this is the differentiating points in between these two drugs. And other drugs in metformin also can use the obese with the diabetes and also glycoside rather than is a sulfonylurea. It has the effects, the 2G effects, means the gain in glycemia, means weight gain and glycemia and hypoglycemia. But if you go through the scenario now, a 60-year-old taxi driver comes to the diabetic clinics for review. He has had the type 2 diabetes 15 years and has now developed the diabetic nephropathy. His blood sugar control is suboptimal. He is currently taking the linagliptin as the monotherapy. Examination reveals that the blood pressure is high, yes, and the pulse 75, and the BMI is 35. Blood results reveal an HbA1c is 82 millimole, means uncontrolled, and creatinine is 205, means the EGFR is 29. So the discussions, the SS box is the knowledge that you know, my dear. So you can, the knowledge, my dear, this 35 means that whenever the BMI is more than 35, so yes, you can use the two important drugs like the liraglutide or maybe the empagliflozin. In between these two, now the difference is you can use the liraglutide or GLP-1 drugs in case of renal impairment, but the empagliflozin or maybe the SGLT type 2 inhibitors is not used less than 45. So here the EGFR is 29, so the best appropriate drug would be the liraglutide. So it is said that switch to liraglutide is the best option. I hope that you enjoyed, my dear. So it is said that in these situations with an elevated BMI, hypertension, deteriorating renal function, intervening with the GLP-1 agonist is the most appropriate drug. This will help drive improvement in the HbA1c, modest weight reduction, and an improvement in the BP control. So yes, my dear, it will help, all helping to potentially also slow further worsening in serum creatinine. There are two brands of the liraglutide like the Victoza and also the Saxenda. Whilst Saxenda cannot be used in severe renal failure, Victoza can. So yes, Victoza has not, however, been studied in end-stage renal disease, should be discontinued in such patients. So yes, the liraglutide cannot be used in end-stage renal disease. So other options are written here. The add empagliflozin. Empagliflozin is incorrect. The SGLT type 2 inhibitors are less effective in patients with renal impairment, and empagliflozin would not therefore the first choice. And regarding metformin, we are not using renal impairment. Once again, that you cannot initiate the EGFR below the 30 and is unlikely to drive a significant improvement in HbA1c control. Yes. So this is another, the exenatide switch to bidureon is incorrect. The exenatide, the active component of the bidureon, should not be used in patients with renal impairment. So this is another drug. If you don't know, so that will be fine. And what is that? So this bidureon is nothing but the exenatide. So it is also is contraindicated in renal impairment. So it's a very good question discussions, my dear. So having the obese, having the renal impairment, yes, we should think about the GLP-1 agonist or maybe the empagliflozin, but it's said that in case renal impairment less than 45 EGFR, you cannot use the SGLT type 2 inhibitors. In contrast, that GLP-1 agonist, there is the gel, my dear, means the exenatide and also the liraglutide, but the most important, the liraglutide, exenatide is not used. So liraglutide would be the best option in your case, my dear. Yes. It's a lovely discussion, my dear. So let's get back a little bit more speedy so that the discussions will be very helpful. The question number 2, the next question, you see, what is the most likely underlying cause of his raised glucose? Very simple. The answer is the type 2 diabetes. So there are different options. You see severe sepsis, type 1, type 2 steroid diabetes, and glucagonoma. 71-year-old man is brought to the unconscious emergency department. His blood sugar level is found to be 50. So I did the differentiating points for the type 1 and type 2. We know very well that type 1 diabetes can cause the DKA, and type 2 diabetes, the HHS, is a hyperglycemic, hyperosmolar state, my dear. So in that case, that we are expecting the blood sugar level to be very, very high. He is a smoker, has no past medical history. However, the GP later states that he is a recluse and has not attended for medical review in many years. His arterial blood gas reveals the hypoxia with normal pH and bicarbonate. So it does mean that the high blood sugar, but the pH is normal, so definitely it's not the acidosis. So only 1 plus urinary ketones, and the chest X-ray reveals the evidence of the left-sided consolidation. Infection is a precipitating factors. So yes, my doctor, so this is very important. The type 1 diabetes, you know about it, the type 1 can lead to the DKA, but in contrast, the type 2 diabetes causing the hyperglycemic, hyperosmolar state. The basic differences in between these two, my dear, I used to describe. My name is Shumanto Kumar Shah, Dr. Shumanto Kumar Shah. So Shah is the main name, my dear, main origin of my family. So the main similarly, type 1 diabetes is nothing but the diabetic ketoacidosis. So acidosis, the last word, is the main of the component of this disease, my dear. Acidosis means, yes, my dear, the pH, the criteria should be fulfilled, my dear. Say that the less than 7.3. Yes, in contrast, the hyperglycemic, hyperosmolar state, this is very much important. The pH can be down, but less than 3.5, but it should be more than 7.30. So it does mean there will be acidosis usually not happened. This is important. But if the acidosis is there, so the pH should be less than 3. Yes, why? Less than 3.4. Yes, 7.35, but it should be more equal. Yes, 7.30. It does mean, yes, mind. So the main differentiating points here, the diabetic ketoacidosis, the significant acidosis should be there, and the criteria that we know about from the lectures, with the simple strategy was the diagnosis, the hyperglycemic, hyperosmolar state. So definitely the diagnosis, type 2 diabetes. Let's get back to the next question slide. Yes. So which of the following is the most appropriate next step in his management? It's a very good question. So it's written here, the gliclazide, basal insulin, pioglitazone, acarbose, and empagliflozin. So yes, my dear doctors, you need to know, as I said, the empagliflozin and these SGLT type 2 inhibitors is nothing but that you can use in a patient obese, and lots of benefits that we are getting, my dear. So if you get back here, you see the 65, the diabetes is uncontrolled 8.1%, creatinine is good, so you can start the empagliflozin. So potassium, sodium, platelets, and WBC and hemoglobin level is normal. And 59-year-old taxi driver comes to the diabetic clinics for review. He has suffered from the type 2 diabetes, and for the past 6 years, which he currently takes the metformin 1 gram BD. He admits to the difficulties exercising because of his job and transgressions with his diet, and which has led to the increase in weight. So weight matter. On examination, his BP is high and pulse is regular, his BMI is 34. So this is very much important. A diabetic patient is uncontrolled diabetes and having the obesity along with the high blood pressure. So these are the two important things that you should, yes, the next step of the management, empagliflozin. So this is very much important, my dear. So rather than the acarbose, pioglitazone itself is causing the weight gain. So this is also causing weight gain. These all are causing the gain, the weight gain, my dear. So this patient is obese and worsening high glycemic control. Yes, the hands, if the possible, he requires the treatment intensification without the hazard of the further weight gain. Out of the options given, empagliflozin, SGLT type 2 inhibitors, achieves by causing the increased glucose excretion in the urine. This is the most positive effect with respect to the weight reduction and causes small fall in blood pressure because of the thiazide-like diuretic effects. Yes, my dear. other drugs can cause a weight gain. Regarding the acarbose, also doesn't cause the weight gain or hypoglycemia. It does cause the flatulence and diarrhea, which might have the negative impacts on his ability to carry the taxi passengers. So regarding acarbose, if you have any doubts, my dear, we are not using that much acarbose. Yes, this is important. So the empagliflozin will be the best option, my dear. So if you get back to which one of the following the contraindication to treat the GLP-1 analogs, this is important, my dear, to know. So you need to know one of the box for the GLP-1 analogs. This is important. Yes, my dear, this is important. It leads to the G for the another box, the gastroparesis. What I say, if you know the GLP-1 is a gastroparesis, so definitely should be contraindicated in patients with the GLP-1 analogs. So yes, the history of gastroparesis is a contraindication for this case, my dear. GLP-1 analogs can delay the gastric emptying, yes, and can therefore exacerbate the symptoms of the gastroparesis and are contraindicated, yes, in patients with a history of gastroparesis. So very simple, my dear. Next question, number 5. Which of the following best describes the pathology or management of this patient's food condition? Yes, my dear. The pathology of this condition is thought to be related to an exaggerated local inflammatory response to trauma to the neuropathic foot. It is nothing but the diabetic neuropathy or Charcot arthropathy. So it's a single line diabetic neuropathy and leading to the Charcot joints, my dear. The simple questions. So if you just read it and write a single line in your notes and get them by heart, it's simple like that the condition is thought to be related to the exaggerated local inflammatory response. So yes, the Charcot's joint, my dear. So let me discuss a little bit further. Good discussions are here regarding the Charcot's joint and Charcot's arthropathy. So diagnosis has a diabetic neuropathic Charcot arthropathy. In patients with the diabetes managed with the loss of sensation, circular sensation, to a joint may result in chronic, progressive and destructive arthropathy. It is multifactorial due to a combination of mechanical and vascular factors, resulting from diabetic peripheral and autonomic neuropathy. Yes, peripheral and autonomic neuropathy and metabolic abnormalities of the bone. Yes. Trauma to the neuropathic foot may trigger an exaggerated local inflammatory response mediated by pro-inflammatory cytokines, resulting in osteoarthropathy. Yes, my dear. So, trauma to the neuropathic foot may trigger an exaggerated inflammatory response mediated by pro-inflammatory cytokines, resulting in osteoarthropathy. As an example, lack of proprioception secondary to the peripheral neuropathy may result in ligamentous laxity, yes, increased range of joint movement, instability and damage by minor trauma to which relatively insensitive neuropathic foot is prone. In addition, the resulting changes in the architecture of the foot causes a change in weight bearing and subsequent localized trauma. Finally, an autonomic neuropathy may result in vasomotor changes and in the formation of, yes, the arteriovenous shunts, and these in turn result in reductions in effective skin and bone blood flow despite the good and sometimes bounding foot pulses in these patients. So as small boxes that we can start, yes, my dear, in Charcot's joint, what happened that the starting point will be here, that the trauma to the neuropathic. So the Charcot's joint, yes, my dear, the trauma is the first trigger to the neuropathic joints is important. The trigger and exertion local inflammatory response. So local inflammatory response. So local inflammatory response. Trauma that leads to the local inflammatory response. Just write it down. That leads to the, yes, the osteoarthropathy. This leads to the osteoarthropathy. That leads to the osteoarthropathy. Because of the some pro-inflammatory cytokines. And this is important that there's example lack of proprioception secondary to the peripheral neuropathy may result in ligamentous laxity. So because of the osteoarthropathy. So if I'm saying that because of the loss of joint senses or proprioception, loss, yes, this is number one, toe. That leads to the ligamentous laxity, increased range of joint movement, instability and damage by minor trauma, to which the relatively intensive neuropathic foot is formed. In addition, resulting changes in the architecture of the foot causes the changing in the vasomotor, changing in the weight bearing and subsequent localized trauma. Finally, the autonomic neuropathy. So just write it down few times. Autonomic neuropathy. Yes, result in reduction in effective skin and bone blood flow, despite the good. So this is all about the Charcot's joints, my dear. Yes. So the Charcot joints is important. Yes. Let's discuss a little bit further. Clinical features classically represent the sudden onset, unilateral warmth, redness, and edema over the foot or ankle, often in the history of minor trauma. The affected foot may be discernibly warmer to the touch than the contralateral foot. Sometimes the patients present instead with a slowly progressing arthropathy, with insidious swelling over the months or years, and occasionally recurrent acute attacks may occur. The most frequently involved joints in the diabetic patients are the tarsus, yes, and the tarso-metatarsal joints. So you need to write the tarsal and tarso-metatarsal joints. Yes, fine. Followed by metatarsophalangeal joints and the ankle, followed by metatarsophalangeal joints and ankle joints. Management avoidance of weight bearing, of course, and number 2 is the tight glycemic control, and number 3, the patients who do not respond adequately to other interventions should be referred for consultation with an orthopedic surgeon with experience in the management of diabetic neuropathic arthropathy to assess the individual risks and benefits and surgical stabilization or other procedures. And the role of bisphosphonates and calcitonin in acute Charcot's remains uncertain. So the summary talk is the tight glycemic control and the weight-bearing reductions in the initial steps to manage the Charcot's arthropathy in the initial step, my dear. Next step is, next questions. The question number 6 is, are considered the conventional SGLT type 2 inhibitors. So which would be an appropriate choice for this women's diabetes management? So once again, the 52-year-old woman, GP routine assessment of diabetes. She was diagnosed with type 2 diabetes, 9 months treatment, treated with the metformin 2 gram, past history of notice, inferior myocardial infarction some 5 years earlier, and BMI is 32, blood pressure is slightly high, and HbA1c measures are 64, there's 8%. So this is very much important to know, my dear. Having the post-MI, of course, you should think about the empagliflozin or SGLT type 2 inhibitors. Yes, my always. So you can write down the SGLT type 2 inhibitors equal to post-MI, having the history of the MI and having the slight blood pressure, and the most important talk, yes, my dear, plus obesity. Yes. So the lots of advantages that we can, the best choices drugs is the SGLT type 2 inhibitors. So yes, mine is written here. So in patients with hypertension, previous MI, significant overweight, whereas SGLT has the advantage of reducing sugar and modest positive effects on weight loss and some blood pressure lowering effect, and is therefore the optimal choice. Why not the GLP-1 is incorrect? But why? Because it means the BMI is more than 35, and long-acting beta known the DPP-4 inhibitors and also the constants. DPP-4 is incorrect because there is no effects on the weight, my dear. So yes, so this is very much important. Prefer is the SGLT type 2 inhibitors. Which of the following is the most associated with food fractures? Is a cannot be frozen idea. So we need to know, yes, the SGLT type 2 inhibitors, yes, there is a cannot be frozen is associated with the small bones fractures, the small bone fractures in the feet. So SGLT type 2 inhibitors equal to small bone, just write down the fractures in the feet. So yes, my dear, the foot fractures is associated with the SGLT type 2 inhibitors. So you must know, my dear, it's one of the important questions that will hit by the last diet, so you can do the best, my dear, in your exams. So other things that, question number 8, which of the following statements about the diabetic ketoacidosis is true in adolescents, in adults, my dear? This is important, adults and adults. What is that? The blood sugar can be normal. Yes, my dear. So diabetic ketoacidosis in adolescents, yes, or adults can be normal, means the euglycemic diabetic ketoacidosis. Euglycemic diabetic ketoacidosis. I'm writing euglycemic diabetic ketoacidosis can be occur. Yes, my dear. So there are so many causes. The answer is the blood sugar can be euglycemic diabetic ketoacidosis is rare, occurring approximately 1% of the decay seen when there has been prolonged fasting during pregnancy and with interruption of the insulin delivery with the insulin pump therapy. Is also a rare complication of taking SGLT type 2 inhibitors. So this is important. We know about the SGLT type 2 inhibitors can cause the euglycemic decay. So we can write down the euglycemic decay in adults is normal, but the conditions that the fasting, you can write down the fasting, prolonged fasting, and then the pregnancy, and once again that the pump. So the pump and pregnancy, P, and another P for prolonged fasting. So write down the pump so that you can remember, make a box, my dear. So prolonged fasting, pregnancy, and the pump. Yes, my dear, the delivery of the pump, and definitely we know about the SGLT type 2 inhibitors also can cause. Other than these drugs, these are prolonged fasting, pregnancy, pump, prolonged fasting, pregnancy, and pump, my dear. Just remember. Now the question number 9, what is the primary cause of the ketoacidosis in type 1 diabetes? The main is the lipolysis. So you can write down the DKA in type 1 diabetes equal to lipolysis. Make a box, lipolysis. Yes, my dear. Lipolysis increases the ability of the free fatty acids substrate for hepatic metabolism, which leads to the accumulation of the acid intermediate and end products like the ketoacids and ketones such as acetoacetate, beta-hydroxybutyrate, and acetone. So ketones are also seen in some and other acute energy deficit. But here, that you need to remember the DK type 1 diabetes lipolysis. The next question, number 10, yes, ma'am. What is the most important immediate treatment? Definitely the IV fluids. The DK, the management minor. We know about the first treatment should be, the first immediate treatment should be the IV fluids minor. IV fluids. So this is very much important. My HHS, once again, hyperglycemic, hyperosmolar state. What is the most probable diagnosis? Of course, the HHS. So if you go to the hyperglycemic, so if you see the glucose level in 50, hyperosmolarity, if you see the hyperosmolarity, you can measure the osmolarity as well. So the state is the pH. You see the pH 7.35 is not the acidosis. So definitely it's not the diabetic ketoacidosis. Yes. So the investigation suggests that this patient is hyperosmolar, the bicarbonate level blood pH with low diabetic ketoacidosis, anion gap just above the upper limit of the normal, certainly contributed by the metformin's degree of renal impairment and rehydration with IV fluids in the intervention of choice. Although insulin is required in acute phase of the illness, it may not be required long term. So Very importantly, that you must know, my dear, the hyperglycemic hyperosmolar state. I'd like to go through a little bit into the scenarios. So this is hyperglycemia. So if you see that you can calculate the plasma osmolarity is nothing but the 2 sodium, 2 potassium, and glucose plus urine. So 2 sodium once again is nothing but the 152 plus 2 potassium once again is 5.5, and glucose itself is 50, and urea level is not there. All right, no problem, but you can calculate. So this is nothing but the 4, and this is 30, and this is once again 11 plus 50.